welcome. We're live in CLDF Liver Connect, the 5th annual symposium in San Antonio. And I'm Dr. Robert Wong from Stanford University. I'm joined with Dr. Laura Kulik from Northwestern and Dr. Parissa Tabrizian from Mount Sinai. And today we're going to talk about exploring hepatocellular carcinoma management trends and the evolving treatment landscape. So maybe to start off, the first question we want to discuss a little bit about is how have immune checkpoint inhibitors changed first-line therapy? And maybe I'll toss that over to Laura.
So I think it's definitely become the first, it is now no longer, should we use immunotherapy versus a TKI? Immunotherapy has become the standard of first-line therapy, except for patients who are not candidates due to concerns for toxicity from an immune standpoint. And the field is rapidly growing. We have another combination, a doublet, which is going to go through FDA approval, hopefully, and it currently has the longest overall survival, Ipi/Nivo, at 23 months. And that was compared to the choice of the investigator, lenvatinib versus sorafenib, which had an overall survival of approximately 20 months. There are some other ones that have not yet been approved. The CARE-310, I think the FDA has, as of yesterday, declined its approval for the second time. So it remains to be seen if that will be approved in a U.S. population. So lots of exciting things, and immunotherapy has its foot firmly in the ground of first-line therapy.
Yeah, it's definitely very exciting. And for those of you that didn't catch us, we had a really nice HCC session here at Liver Connect. They really talked about sort of emerging trends with systemic therapy and sort of how we combine that and approach that with local regional therapy. Dr. Tabrizian, you've done a lot of work on sort of exploring how to incorporate some of these approaches pre-transplant, and especially for challenging patients that may not otherwise be eligible for transplant. Can you tell us a little bit about that and sort of your work in that area?
Yeah, so we really, over the past, I would say 10 years, pushed the envelope and trying to capture and trying to cure more patients and realized that tumor biology really is key in the decision-making rather than size and number alone, which was when the transplant criteria was established for HCC in 1996. And over I would say the past 10 years, we've published many large studies, prospective studies, where we established that downstaging in patients who were successfully downstaged to within Milan and were transplanted had successful long-term results. And even in the advanced stage, there is in select patients, you can still achieve meaningful outcomes. So it becomes a little bit more tricky now with the use of immunotherapy. There are, to date right now, 2 large randomized controlled trials in the intermediate and advanced stage that showed promising results. One study was the Emerald-1 study that looked at the combination of Durva and Bev in plus TACE. And the other trial looked at the combination of lenvatinib and pembrolizumab plus TACE, the LEAP-012 study, which may become the standard of care in the intermediate stage, but is still pending overall survival results. Now, if this is going to become the treatment choice pre-transplantation will be determined. We have done a lot of work in a multi-international setting on looking at the validity of immunotherapy in the pre-transplant setting, also with very encouraging results. But we're still awaiting results of clinical trials in order to answer a lot of the unknowns.
Yeah, it's really exciting. The field work that you and others have done have continued to really push the envelope and really expanding opportunities for treatment for these patients that otherwise may not have access to therapies. At our session, we had a really nice talk by Dr. Sid Padilla from UCLA. They really talked about advances for local regional therapy, particularly Y90 for locally advanced HCC. And then in your talk, Laura, you really tried to bring together how we're approaching the unresectable HCC and sort of how we think about our approach to combining systemic therapy with local regional therapy, where it fits, how to approach, and sort of how we tackle that challenging problem. Can you share with us sort of what your approach is?
So at Northwestern, we have been using, we're very upfront that Y90 is our treatment across the BCLC at our institution. And we have been using combination therapy as our standard since the days of sorafenib in select patients. Now, currently, we are using immunotherapy. We have an internal study that we're looking at the combination of Y90 followed by the two various approved systemic therapies, the Iron Brave 150 trial and the STRIDE. And then also, if people are not candidates for immunotherapy, leaving open the TKI approach. So probably not going to recruit enough people to really get an answer, but trying to see if there is a, kind of to the work that Dr. Tabrizian has been doing, this combination, and do we get people to transplant? What is their long-term overall survival? So I think this is the way the future is going. There are various trials that are looking at this, Rowan, Emerald, Y90, specifically looking at Y90 with systemic therapy. It may be more immunogenic. And the other thing is now we know that Y90 is just not done in one standard way. We know that we should be boosting the therapy into the tumor, sparing the surrounding liver in order to obtain greater response rates.
Yeah. And one question that came up during the session, and it's a really practical question, first I'll ask Parissa and then I'll jump back to Laura, is we've seen in all these studies, there's a lot of different patient characteristics, tumor characteristics, size, response to treatment that really help us try and identify and select patients better for treatment or transplant. And so what are your thoughts on what are the predictive factors or important predictive factors we have today? And then potentially looking in the future, what can you foresee as potential aspiring factors and that may reflect tumor biology that might, for you, select the best patients to undergo these protocols and kind of bridge them to transplant?
Very important questions. I don't have the answers to many. I think it becomes a little bit more complicated now with the immunotherapies. I think smaller trials will also help us in the decision making. I think, biology, biology is key. Now, I think time also, I think not rushing patients into transplantation, giving a test of time, I think makes sense. Looking at the response, having good imaging modalities, maybe modalities that will improve also over time, that will help us in the decision making. Biomarkers for sure, we have good tumor markers, but I think we can do better. And then also in the with patients on immunotherapy, I think if we learn more about their molecular profile, understand who are the patients who respond and who are those who do not respond, who may recur very quickly after a curative treatment, will be important. I think in the future also maybe AI will help us in the decision making, and liquid biopsies. ctDNA is now a very hot topic in HCC. We'll see.
Yeah, such a hot topic is sort of this whole concept of personalized medicine or kind of tailoring therapies. I think it's really, really exciting. And maybe I'll turn the same question to you from an approach to local, regional, and systemic therapy for non-transplant candidates. What are you using now to kind of help predict or identify best patient for best treatment? And then same question I had for Parissa, looking in the future, where do you see the field going in terms of these biomarkers or kind of ways to personalize care?
So I think radiomics is going to be very key. Our radiologist who's at our tumor board will look at a tumor and say, that's a bad behavior. It's got diffuseness. It's not quite, it's not infiltrated, but the tumor looks like there's going to be vascular invasion within the lesion. Making more use of that combined with AI to figure out who is going to respond. Ideally, we'd like to have a biomarker for immunotherapy response. We currently know this is about 30%, increased to about 40% when you combine with another agent like a TIGIT. That's another trial that we're waiting the results of, Skyscraper. So as more people maybe do biopsies, will we be able to tease out a response to immunotherapy? Currently, there has not been one, and there's no doing next generation sequencing. There's no targeted thing that we can use for therapy. So it's very exciting as the therapies become more and more and we build on this, and perhaps we will stumble upon something that will give us an idea of who is more likely to respond. But currently it's kind of trial and error. If someone is otherwise a candidate, I tell patients we will not know until we see your response, and then wait, as Parissa said, giving it that test of time. And seeing an AFP go from, 6,000 to normal is very, very encouraging. And then giving that person some time to wait and see if transplant is going to be feasible.
Yeah, so interesting to really think about. I think this was sort of brought up at the session too. For HCC, we're not really doing biopsies for these patients routinely, and we don't do that to kind of guide care. Of course, there's different challenges associated with that, but maybe in the future that might be something that we will be doing. And then maybe one final question I was just thinking that didn't really come up during the session, and this is regarding potential living donor transplant, because that was kind of paused for a little bit in the US and then maybe starting to pick up a little bit. But does the potential for living donor transplants change your approach or calculation to any of these patients? Are there different or unique considerations, or you sort of still approach it similarly?
We're trying to be very select and trying to be safe and keep, a ethical consideration with every patient that we approach. But no, I think we don't do anything different. Certainly the living donors understand this is a high risk. And same goes with, the patients now we're transplanting with high tumor burden without immunotherapy. I think we have to have an honest conversation with the donors. But yes, and I think over time now, particularly in the US and Europe as well, we have other resources. We have the machine perfusion that will perhaps allow us to use livers that would have been discarded in the past for particularly patients with liver cancer who do not have living donor options, who are low on the list and may not have potential of cure. In addition, also, I wanted to, since we're only talking about transplant, also maybe also point out one aspect of HCC and resection that we need to do more work on is the adjuvant setting. I think we have had, unfortunately, so far negative results in the adjuvant setting, and it would be very nice to see, and hopefully soon to see a good treatment option in patients who post-resection have an option to decrease recurrences.
Yeah. So, we're going to wrap this up. Again, for those that didn't catch us at Liver Connect Live, I think these materials should be available on the website soon. And maybe I'll ask each of us of this session, what were your key one or two important takeaways? And I think, I'll start for me, being not very well read in this field particular, I found it really amazing just the advancements with local regional therapy that have been accomplished, and all the literature that's presented, especially the Y90 literature with 80, 90 plus complete response rates. I mean, that's pretty remarkable compared to maybe 5, 10 plus years ago. So that was really exciting for me. The second thing that was really exciting that I saw is what both of you have sort of mentioned already, is sort of how we're continuing to push and incorporate systemic therapy plus local regional, either adjuvant or neoadjuvant, to really continue to push that survivalship more and more, and really creating a lot of opportunities for our patients. So maybe I'll start with Laura. What are your one or two take-homes?
So for me, listening to our session, I think it just hammers home for me the point that all these patients deserve, unless there's an absolute contraindication, they're 90 years old, they have horrible hearts, that these patients deserve a evaluation by a multidisciplinary tumor team, because you don't know how they're going. They may present with a very high AFP, portal vein invasion, and you have no idea how they're going to respond. And if they do have a robust response, you want to move on, starting to look either for a living donor, trying to apply for a special case to get them exception points. So I think that as we see, and it's not going to be everybody, unfortunately, but as we see that there are these more and more of these kind of like wow cases, that patients should be evaluated by a transplant multidisciplinary tumor board in order to get their foot in the door as they evolve through their journey to see if either resection or transplantation is feasible for them down the road.
And then Parissa, your one or two key take-homes?
I echo to everything that was said, but I think we're entering a very exciting era. I'm looking forward to the next 10 years. I think one is also the collaboration between everybody, finally bringing everybody together, including the oncologists who for a long time only had like one single drug. I think it's will be nice to continue to collaborate together, and more importantly, I think it's very important for us to put together very meaningful clinical trials since we're rapidly evolving to help understand what we're doing and what and how we should change practice based on that.
Yeah, no, that's it's very exciting. And again, I want to thank all of you for joining us. Again, I'm Dr. Robert Wong. I'm joined here by Dr. Parissa Tabrizian and Dr. Laura Kulik, and we're here at the Chronic Liver Disease 5th Annual Liver Connect. Thanks for joining us.